It is still used for hospitalized patients who are the sickest because it helps guide therapy. Imagine if you're a person with an illness, a respiratory illness, in the outpatient world, you're at your home, you don't feel good. What we recommend and what is recommended is to wait it out, go home, and get better. And better means like 72 hours after you no longer have a fever, you're feeling better, then you can go about your merry way. Or the other way to say it is it might be 7 days or so after the onset that you can wait it out at home. So minor illnesses, colds, allergies is not coronavirus, even in a community transmission, in this case county. But we will continue to test hospitalized and ill patients that are ill enough to be hospitalized because it guides therapy. 150 to 200 tests a day, been pretty steady at this point. Quarantine. There's always questions that come up about voluntary quarantine, mandatory quarantine, and isolation. We're still recommending voluntary quarantine for those patients, and these guidelines are on our website. We've been over them before. I'm not going to repeat them. For those that have come from certain countries and certain states, and in the case of Colorado, counties. And voluntary quarantine is still recommended, and those guidelines have been articulated before. It's important to note that when somebody, a hospital worker will say, is in the hospital taking care of patients, even patients with coronavirus, wearing the proper PPE, masks, face shield, gowns, and gloves, that person is not really exposed to coronavirus. So it's not like their family should be afraid to let them go home. They are protected. They are not at even medium risk for coronavirus. They don't need to be quarantined. And one of the things that we're trying to work with really everybody in the state on is what are the critical infrastructures? How do we manage, because we can't pull firefighters out who have had a low risk exposure, whether or not they're tested, a low risk. We have to have firefighters, police, medical personnel, and we would consider people in the food production industry, farmers, and I had a wonderful chat with Tyson yesterday with their food safety and their leadership to make sure that we are synced up around this critical infrastructure issue with Tyson. They're food producers. But we do, and we don't want to have anybody exposed to somebody that's infectious or could transmit the illness, but we pay particularly attention to those people on the critical infrastructure side. The rest of the people, again, we recommend voluntary quarantine at home and to wait it out. You're going to be hearing from us on child care guidelines. Our agency, KDHE, is recommending continuity of operations for licensed child care facilities with certain guidelines in place, and you're going to be hearing more about that as that comes out. Child care is critical service to the state, especially since employers are having people at home and for a period of a couple of weeks, we'll say, they still need child care when they go back to work. So we can't just pull out child care. You're going to see some recommendations about that. I think something you'll find interesting. Today I had the initial meeting with a really terrific group of people, all of our critical care physicians in the Kansas City area. We're bringing the Wichita people in as well. And we're putting together a group that is headed up by a very experienced person to look at the high-level view of what happens when we get more and more critically ill patients, what happens when we get more and more needs for ventilators, critical care beds, et cetera. And how do we think out of the box? How do we utilize current hospitals well? How about if it gets to a point where we need additional hospital beds that aren't even in service now? What kind of alternative care sites would those be? Would there be a reason to use hospitals that have been closed for any reason with maybe low acuity patients? When do we, I think you know that I'm in the Army and I'm a medical officer in the Army. When do we use and activate combat medics to assist at the bedside? When do we look at having mutual aid agreements across state lines, for example, for having providers from other states come in to provide manning assistance for that? That's the high-level planning we're doing right now. We're not anywhere near that right now. We have the capacity right now to do the work we're doing. But we are looking down the road. What happens if this is not seasonal? What happens if it doesn't drop down in spring, summer, fall? What happens if, and as I talked to the legislators the other day about the Nike swoosh, but the emblem, the Nike. What happens if we have a Nike swoosh and it just keeps going on the up and up? That's what this team we're putting together, of very experienced persons, will help us with. They have a lot of experience in advanced preparedness activities. So in summary, 2 weeks ago we were talking there would be no new patients today. There was a new one yesterday, 2 the next day, 3 the next day, a couple days, maybe just 3, and now we're up to 10 a day. This is a trajectory I think we're going to see. That is why we must continue to emphasize and reemphasize to people, don't be dumb. Don't go to Padre Island. I shouldn't pick on Padre Island. But the beaches are crowded there. That's a bad idea. Kids on spring break, you've probably seen that even on the internet. So do we all need to, do 3 million people need to shelter in place in Kansas? We're not there yet. That's what they're doing in California now. 40 million people are sheltering in place for a 2-week period of time with only essential activities allowing people to go out there. We're not there. Will we eventually get there? I don't know. If this is not seasonal, if it doesn't drop down, I think we see a continued uptick in the number of cases, then we could be looking at, I think, more invasive activities, but we're not there yet. One of the things that I think you'll be seeing, and you'll hear it here in the next couple of weeks, is, I think, better forecasting. Because with every additional week that goes by, even with every additional case, we're drawing and connecting those dots. Will it be a Nike swoosh, like I said, or will it peak out and drop back down? That's yet to be determined. But I think even in the next week or two, I think we're going to have a lot better ability to project. This is how we think, and that is, these are the lines of effort. This is right out of, and I'll just tell you, when I was deployed in the Middle East, I found that this was a very productive way to think, was what are the lines of effort? How do we make sure that these various buckets of activity, that we're not missing anything? So we review our lines of effort: epidemiologic and disease tracking, bread and butter, public health. 2, community testing and lab testing alternatives. We've talked about this every day. But we have people looking at new and different ways of doing things. For example, what they did in Colorado with the drive-through probably didn't work very well. It shut down because of so many of the worried well or anxious people that were, some not even ill at all, were going through and being tested, and they quickly exceeded their testing capacity. And when you exceed your testing capacity, that means that you're going to have people that really need it that don't get tested. 3, the media and community education engagement, part of the activities that we're doing here today. What is the highest quality education materials we can get out there, and what are the methods to communicate that? It's really critical we get buy-in about embodying these recommendations we're saying. Isolation and quarantine management and enforcement. Fortunately, there hasn't been any need to enforce the quarantines in isolation. People have been voluntarily doing it. I would hate to see it come to that. Policies and guidelines, and these are changing, and when we make subtle changes in policies and guidelines, it really throws people for a loop. So always want to be looking ahead. How do we bring in and form the best policies around this? Community relations school and local health department liaison functions. The whole world doesn't exist here in Topeka, Kansas. They have all this activity statewide, and they're very close to the work. They are closest to the work being done. So what is it? We're bringing aboard a person to help us, a very experienced public health practitioner, herself a former health department director, who is going to come just to help with to serve as the liaison function with the local health departments. best practices research. We're not alone in this globe. There's a lot of great research being done. Italy, for example, and stuff coming out of there every day. We don't want to get so busy with our day-to-day activities that we're asleep on the switch about some things that are coming out. I know we're engaging some of our infectious diseases practitioners to say there's some remdesivir and chloroquine trials being done. At what point, that's an antiviral. It's not approved for coronavirus. Chloroquine, a long-time malarial drug, not approved for coronavirus. But it seems that there's early indication from China that maybe they're beneficial for coronavirus. I don't want to be asleep at the switch when it comes to the best practices research. So we have the KHI and one of our former epidemiologists from here who is on a at least temporary basis coming aboard to help us scan, because we need somebody to scan all the time the external world. And finally, near and dear to our heart, materials, supplies, and stockpile. We just yesterday, oh, this is important, just yesterday we got 2 semis full of supplies, masks and face shields, gloves, and gowns. I think it was 2 days ago, we supplied 10 counties with supplementary PPE. Today, I think probably sent 20 different shipments to different organizations. And they're routing it through emergency management, going really quite smoothly. And it's great seeing these semis back up and unload their pallets. So in summary, coming into the weekend, no shortage of things to do. I expect the trajectory, hopefully not as steep as the Nike swoosh, but I suspect the trajectory will be that we'll continue to have increasing cases at the current rate. Any questions?
I know we're not like the population of California where they're advising everyone to stay at home. If it got to Kansas, would you break it down by the state or by counties being, what would happen first?
I think that's really, how do you go from where you are to the end game, if you will, on that? And I think it can make sense to have it be where the highest spread is to have those folks. Again, just like Governor Newsom said in California, they're doing it on a voluntary basis. They hope to get good buy-in from the public, and we would roll it out in a similar fashion, I think. Because I spent a lot of time, matter of fact, I did a radio broadcast earlier today from a Garden City radio station. It's different in western Kansas. There's a lot of elbow room between people.
You mentioned that you have, how many test kits do you have left?
I think about 300.
So that would be gone by the end of tomorrow.
Mm-hmm. Yes.
First question, what happens if you run out of testing kits? Second of all, where are you looking to get them?
Right. Well, we have friends that at the commercial labs, we would, by definition, need to shift more of the work to the commercial labs. We also are assisting hospitals, particularly the Kansas City and Wichita hospitals, which, by the way, not a surprise, and when I say Kansas City, I mean Kansas City Metro, assisting them on coming up to speed so they can do their own testing. This does not have to be, it does have to be an FDA-approved process or an FDA-approved kit at a sophisticated lab. But once the hospitals have the ability to do the testing, then the pressure is going to be off our state. So we have the capacity out there. We just can't do it all.
Mr. Secretary, I've heard a couple of presentations by you, and you've received some skeptical questions from individuals. What do you think about the naysayers?
Well, I've had a career that people didn't always agree with me, so it's. I think a lot of times it's just a matter of saying, let me understand, let me hear what you're really asking, and to try to provide the rationale as to why we are making the decisions we're doing. If people are entrenched in ideas that there's a conspiracy or a deeper plot, or then I probably can't change that. So I try to engage people first by hearing what their questions are and answering, and then just say, well, I'll be open-minded and I'll continue to listen. Because we accompany each other through this, and especially if it gets more and more difficult, we cannot marginalized. We have to accompany our citizenry through this decision-making process. So answer questions, listen, and be kind.
You mentioned that I think Kansas is not at the point of, say, California, where they're having the stay-at-home order. I think Illinois might have issued something similar in the last couple hours. But can you help me understand if the aim is to slow the spread of the virus as quickly as possible, why not deploy the maximum, I guess, powers or what have you now, as opposed to waiting until the virus spreads?
Yeah, good question. There's not a bright line where you say let's do a big intervention because we've crossed that bright line. And does that work? Even what you're suggesting, and we know from Italy, for example, and I don't want to get too deeply into the epidemiology and sciences, except to say, if you say we sequester people, everybody away in their homes for 14 days, there are still going to be people that come out of that are positive for coronavirus because they were occupied, they were incubating, and they were maybe getting toward the end and are coming out. So you can push it down, but I think what we're going to see is what we're seeing in Europe is you isolate, and then you take people out of isolation, the whole population of people. You get an uptick, you do it again, and an uptick, and do it again. And we don't live in a bubble. You know, we're not hermetically sealed as a population. There's always going to be incursions and returning. So it is great, though, for kicking the can down the road until we get vaccine or antivirals. So I don't know exactly what that bright line is, but if we get to too many cases or pushing our capacity to take care of them, then I think that's what that would be. Because the way I look at it is every month that we get farther down the road, the closer we are to a vaccine or antiviral medications, and that's the goal.
Do you know about how many would be too many cases?
That's what this group is going to find out. And I've asked them, as they form this group, they're not going to be meeting an hour a week for the next 8 weeks. They're going to put the pedal to the metal and really come up with exactly, because we know how many ventilators we have. We know how many are in the pipeline to purchase. We're going to purchase some number, 100, 200 ventilators. That's exactly the capacity analysis that we're going to do. I can tell you how many ventilators we have now, and I can tell you how many critical care beds and staff we have to manage them. The big question is, what do we forecast as to the need? Because we will forecast not only how much disease there is, but what percentage of it is severe, what percentage of it needs to be intensive care beds, what percentage of it requires ventilators, and what percent of people are not going to survive. And we'll report that to you as we do that analysis, because I think it's information not meant to scare, but it's meant to be helpful.
So other states, what is it, the hundreds that maybe they start shutting down?
It depends. It would really have to be on a per capita basis, because we're a small state, and we'll report it out on a per capita basis eventually.
Mr. Secretary, you said that the state has about 300 testing kits left. If I understand correctly, those testing kits can test multiple people. Is that right? Or?
That is, yeah. There's mini kits and then regular kits, and don't hold me to the numbers, but it's something like 15 per kit. I'm talking about patients.
Oh, so we have the capacity to test about 300 patients.
Patients, yeah,
Okay.
yeah.
If we run out of those, I mean, is that actually likely that we will, and would you guys just start assuming numbers? How would that affect the numbers that we're seeing?
Well, what we would do is we would hold some in reserve, quite honestly, for the ones that are particularly important, probably in a sick hospitalized patient where you really need to know it or not. And otherwise, we'll just say because we would say to use a commercial lab. Oh, and by the way, one of the things we've done, particularly for Western Kansas, is our environment. So we have Kansas Department of Health and Environment. One of our whole divisions is environment. We've got field service offices all around the state. They have cars there, and we're deploying our environmental staff to be couriers. Because one of the problems was, I was talking to somebody in Liberal. They, FedEx and what's the other one? Anyway, those kind of services don't work necessarily every day of the week out there. They couldn't get a sample. But we're going to to help by deploying our environment staff to be couriers, essentially.
But if you run out of test kits, you will just tell people to use private labs?
Yes.
It won't be like testing will stop?
Right, no. And matter of fact, Starmont Vale, KU, we've been working with them to have a mixture of stuff sent out and stuff stay. Our turnaround time is shorter than what the commercial labs are. One more question.
Well,
That's
what is
similar.
it,
Martin.
what's happening to poor people that don't have a doctor they can call? Are we taking care of Medicaid folks? Like, I don't even know how to phrase the question.
Yeah, I know how to,
Better than I do, but
yeah.
What's
Well,
happening with that?
Well, first off, Medicaid folks have doctors. I mean, they're insured with Medicaid. And so they're just like any other commercially insured patient. The real question is on homeless or shelter. And we have done diagnostic tests on homeless and people living in shelters, but they'll typically go to the emergency room. Not ideal. This would be a great opportunity to expand Medicaid, because a lot of those people you're talking about, Martin, are also the ones that could be covered. Makes it a lot easier.
More doctors aren't treating Medicaid patients.
I'm sorry?
Aren't more doctors refusing to treat Medicaid?
No, I think that most physicians do. I always do. Thank you all very much. Good to see you, and we'll be back on Monday.